Good afternoon. Welcome to today's webinar, sponsored by the Childhood Obesity Intervention Cost Effectiveness Study, or CHOICES, as most of you know. And the topic for today is investing in prevention, how a clinical strategy in Denver could improve health and address health equity. Today, we're going to share data from CHOICES and its impact on Denver, how cost effectiveness thinking can help identify important and likely interventions that are low cost, and to hear particularly from Denver Health about how they use this technique to address the problems of obesity in their settings. So we're going to highlight strategies today in the healthcare setting. That's a bit of a departure from prevention, but we're going to get into just why that is. If I could have the next slide, please. So today we're going to have a great panel, beginning with Heidi Blanck, who's branch chief for the Chronic Disease Nutrition Obesity branch in the Division of Nutrition, Physical Activity, and Obesity at the Centers for Disease Control and Prevention. We're also going to have particularly Jennifer Moreland, who is the Chronic Disease Manager in Denver Public Health, where she also works and coordinates teams working in clinical and community settings, and facilitates strategic planning for a collaboration of 6 Metro Denver health departments with a common goal to increase healthy food and beverage access. And in addition, we have Elsie Taveras, who's the Chief of the Community Health Equity, who's the Chief Community Health Equity Officer at Mass General and the Brigham in Boston, and the Executive Director of the Kraft Center for Community Health at MGH, and the Conrad Taff Endowed Professor at Harvard Medical School. So in today's session, we're going to have a panel discussion. To begin, I'm going to ask the panelists questions, and all of you who are on the webinar can submit your own questions in the Q&A box anytime through the presentation as we turn to the audience questions. If I could have the next slide, please. So just at the beginning, CHOICES engages in research and education, and the information presented in this discussion today is for educational purposes only, and does not necessarily represent the position of any CHOICES project funders. And the event is intended to provide information, tools, and resources to inform and educate the audience, and not an attempt to influence any legislation. So let's begin with you, Heidi. The prevalence of childhood obesity in the US has increased steadily over the last 3 decades, and new studies would suggest that disparities have also increased. Could you please bring us up to date on the latest findings?
Thanks, Bill, and thanks to the CHOICES group for having me today. Shown in the slide here is data from our National Health and Nutrition Examination Survey, what we call NHANES. And as Bill suggests, you can see here from the data we have in youth 2 to 19 years of age. When we look at the prevalence of obesity, which in this population is age and sex specific BMI percentiles of above, we can see that over the course of the last 50 years, unfortunately, in the US, we've been seeing a steady increase in childhood obesity. When you see the data on the right-hand side of the slide here, you can see our latest data from the last 20 years. And although we've had a few opportunities with some flattening, unfortunately, among all age groups, we're continuing to see this high magnitude of obesity. The prevalence, for example, is almost 20% in our children that are between the ages of 12 and 19. Next slide. I also wanted to point out some of the data from our latest NHANES survey. This is the data we have from the 2017 to 2018 period. The data in these are specific by age, by sex, and by race ethnicity. Looking at the left-hand side, you can see, for example, that childhood obesity increases by age. Unfortunately, though, we have way too many children entering kindergarten already having obesity. So for example, here with boys and girls, we can see 15 and 12% respectively already having and struggling with obesity at 5. And then we see it continuing. We do see these gender disparities where we have slightly higher prevalence of obesity among boys versus our pediatric data with girls. On the right-hand side, just looking at racial and ethnic disparities, the examples here include non-Hispanic white children, non-Hispanic Black, Hispanic, and Asian American children. And unfortunately, we have way too high of obesity, and we do see these differences So overall here, using non-Hispanic whites as a comparator group here, you can see this almost doubling of obesity, for example, in non-Hispanic Black girls, so 29%.
Great, thanks, Heidi. I wonder, I know that CDC has been very active in addressing obesity across the country in communities and states, and particularly more recently, the role of the clinical sector or healthcare setting. I wonder if you could elaborate a bit on what you're trying to achieve there.
Great, and next slide. So a lot of the approaches that DNPAO, or my Division of Nutrition, Physical Activity, and Obesity, taken part in have been in this community-wide prevention area. So this is work we do in groups like early care and education or schools. But as this slide points out, there's much work that can be done in clinical, in the bucket we call the innovative clinical prevention. So as folks know,
Heidi, we're losing you. I don't know whether you can come back in or not.
Is something that we've really worked with a lot of communities, and the work of Jennifer and Elsie and others today will highlight where we have innovations in the clinical care setting.
Great, thanks. So Elsie, we tend to think of public health approaches to prevention as community-based. Why should treatment be considered a prevention strategy?
I think what Heidi just showed is that obesity begins early, and there's quite years and years of evidence that once present, obesity is very difficult to treat. And so in some ways, if we are able to modify and interrupt that cycle of developing obesity, it is a form of treatment. I do want to also, before jumping in, start by thanking again the Choices Group for putting this together and for just convening us and thinking about, broadening the discussion, just as Heidi presented about the importance of clinical intervention. So really excited to be part of the panel and being joined by Heidi and Jennifer to talk more about it.
So Elsie, you've also had extensive experience in developing interventions to prevent childhood obesity and address other chronic diseases, especially in underserved populations. What do you think are the most promising clinical interventions?
Sure, and I have the next slide. I'm going to talk a little bit about our own interventions. But before I dive into those, your question is a good one, Bill, of what works, and particularly how do we approach management from the primary care perspective, in addition to what works from clinical management, right? So obesity, very specific obesity management clinics. And some of the work that I have done has focused on that primary care interface of primary care clinicians with their patients. We've also done work to understand what are the components of a healthy weight clinic that I'm not gonna talk as much about here. I guess to tell you a little bit of the two interventions that we're going to talk a little bit more about today, and that Jennifer is going to describe the implementation of in Denver. I'd like to give a little bit of historical perspective. So we designed the STAR study, the study of technology to accelerate research, in 2009. And it was at a time when there was a lack of standardization of the clinical approach and primary care approach to children with obesity. There wasn't kind of consistent use of screening for a child's body mass index, documentation of that child's body mass index, nutrition and physical activity counseling, and following the guidelines of the U.S. Preventive Service Task Force recommendations. There wasn't really a good sense of a baseline of how much these topics were being covered in primary care. and not a very good sense of the documentation, not just was it covered, but was it being documented? And so one of the first interventions that we designed in 2009 was the STAR study. It was really meant to address that the need for clinicians to have at the point of care the kind of set of tools that they needed to provide high quality care for children with obesity. And that original trial, the STAR trial, was a 1-year cluster randomized trial where we randomized and enrolled 14 practices and about 550 children ages 6 to 12 years to three different interventions in their clinical health center. One of the health centers received electronic decision support in the electronic health record. We did this at a time when many community health centers, many practices were receiving federal funding to shift from paper records to electronic records, and we wanted to leverage that shift to electronic health records to be able to, again, put decision support at the point of care for clinicians managing children with obesity. So we tested a clinical decision support with kind of self-guided educational materials for parents. In addition, we tested a clinical decision support with health coaching, which is much more time and cost intensive, and compared the outcomes of children in those two arms to children who were receiving usual care. We found after that 1-year intervention that children, that the clinical decision support tools that we created, whether they were accompanied by the family education materials or the health coaching, were effective in improving child BMI and effective in improving the quality of care that children with obesity were receiving in their primary care sites. We then decided in our second kind of adaptation of the STAR program to develop the Connect for Health pediatric weight management program, which was also, in the previous slide, a 1-year RCT that enrolled, there were several adaptations, I would say. We wanted to know if the intervention could be adapted to children beyond 6 to 12. So we wanted, because the US Preventive Service Task Force recommendations were to begin at 2 years of age, we wanted to test if the intervention was just as effective in younger children. We also wanted to think about that very time-intensive and costly health coaching, and if there were other ways that we could support that counseling of families. And so we introduced text messaging, and I'll tell you a little bit about that in the next couple of slides. The next slide. Both interventions for STAR and for Connect for Health had clinician-facing tools that were shared in common. At the point of care for children with obesity coming into to see their clinician, we created a flagging, a decision alert that would trigger for children at the day of their visit with a BMI over the 85th percentile. And that flagging allowed clinicians, again, at the point of care, to have access to the recommendations for counseling on nutrition and physical activity and sleep, for any laboratory evaluation that needed to happen at that visit, and for assessing and developing a clinical plan for management. We also did quite a bit to train clinicians on knowing how to deliver high quality care for children with obesity in primary care. Both interventions also had parent and child facing tools. In STAR, most of this was delivered either at that visit with their clinician or mailed to them. In Connect for Health, we later introduced text messaging, which is actually on the next slide. Taking advantage again of the technology when we developed Connect for Health in 2013, the emerging use of text messaging. Connect for Health introduced the counseling and coaching of families through text messaging to, again, reinforce behavior change support for families. So as a bigger picture, I think there are some potentially better practices that are demonstrated in STAR and Connect for Health, the flagging of children with obesity for primary care clinicians, being able to support families in behavior change, being able to establish with a family treatment plan. And I would say that the other potentially better practice out there is linkages of children with obesity and their families to community resources. So that's not just in our own research, but as I scan what are some best or better practices, I would say that those are part of the components of some of the effective interventions out there in clinical settings.
Great. Thank you, Elsie. Now, turning to you, Jennifer, Denver Public Health participated in a one-year training and technical assistance program with Choices. What interested you in this cost effectiveness perspective, and could you share a bit about what you found?
Before I talk about Denver's interest, I want to speak a little bit to who we are in Denver. Denver Public Health is a local, nationally recognized health department that is housed at Denver Health. And Denver Health is a large safety net provider that provides care for all patients regardless of ability to pay. And we are the largest provider to Medicaid beneficiaries in the city and county of Denver. And this interest really stemmed from our community health improvement plan, which identified a goal of increasing children at a healthy weight. And so it was really important for us to identify strategies that could move the needle on this. And so for that reason, we were very interested in collaborating with the Choices team to understand what those interventions might be. Because while most people might think of Denver as a very healthy community, actually at the time of participating in 2017, and unfortunately still today, 1 in 3 children have too much weight for health in Denver. And so one of the interventions that we selected to model was the STAR intervention. And specifically, we were interested because Denver Health serves more than 1/3 of Denver kids. And we had a number of programs for our children at highest risk and also suffering from comorbidities. And we felt like the STAR intervention might be something that could reach far more children and also with much fewer resources. And then specifically for kind of the nuts and bolts pieces, the STAR intervention was something that was built for Epic electronic health records, and that's what we use at Denver Health. And so some of the results that I'd like to share are here on this screen. And so what we did indeed find is that the impact was really far-reaching in terms of being able to reach a large patient population. And then we also recognize that this was an intervention that would be able to impact health outcomes. And then it was also nearly cost savings in terms of the cost to implement it was really promising in terms of for every dollar invested, there was 78 cents on the return. And next slide. So a lot of really key things in terms of this being a great value for the money and reaching a large population, but also what was really important to our stakeholders was making sure that this had promised to address health inequities. And as you can see from this slide here, because of the population that we serve at Denver Health, primarily Hispanic and Black populations, and recognizing that those populations suffer disproportionately from too much weight for health, this was a promising strategy, at least in Denver, in terms of being able to start to address health inequities. And we recognize that these populations, that there are these drivers of inequities, mainly systemic racism, that these populations, primarily Hispanic and Black, really are populations that are experiencing much more exposure, negative exposure to things like sugary drink marketing and unsafe places to play, and much less exposure to positive environmental influences like grocery stores and walkable neighborhoods.
Great. So I'm curious about how you've used this cost effectiveness data and other lessons that you've learned through this work.
Working with the Choices team, we were able to develop a number of infographics and briefs and some reports. So we were first able to share back with the stakeholders who we convened for selecting the interventions and supporting us with the process. And with this information, we also were able to share it out with the community and specifically offered presentations both at the local level, regional, state, and national level. And then in reference to making sure that we could support moving the needle on our community health improvement plan, we also shared this information with the Mayor's Policy Review Committee. And then what we really learned was that this information was really helpful in making our case in terms of why this might be an effective intervention. And not just the results, but also I want to share some comparisons. So on this first slide here, what we were able to really share is that even in the context of other clinical interventions, that the STAR intervention really can be an affordable intervention and still show in comparison some great results in terms of having an impact on BMI. And the point I want to make here in terms of the difference between the Denver STAR and the national STAR is that in Denver, when we modeled this, we recognized that the component that was really costly in terms of mailing might not work well for our patient population, because we recognized through past work that we had done that mailing was not the best way to reach our patients. So we really made a substitution that was using text messages, and that helped to lower the cost. And then on the next slide, not only is this a promising intervention in a clinical context, but also a very promising intervention in comparison to some of the other interventions in the community. And so we can see here in terms of the cost that we're falling somewhere in the middle and still able to demonstrate a really reasonable cost for an intervention, and then also still performing really well in comparison with BMI.
Yeah, so
and then the last point,
the
last point I want to make is in terms of this information was really compelling to be able to attract funding. And for this reason, in terms of having this investment from our senior leaders and having done this work in our planning, this really led to the invitation from Elsie to work with her team to be able to implement and start to implement this intervention.
So these results in terms of cost effectiveness are really stunning. And I gather that a good part of the reduction in these costs comes from the text messaging as opposed to other strategies. Is that correct?
Yes, the text messaging was a really useful piece in terms of being able to lower the cost of the intervention.
Yeah. So I'm curious, and I don't know whether others on the webinar picked up with this on this, but you mentioned that this was about too much weight for health framing. How'd you come to use that terminology?
Thank you for asking. I recognize there's some discrepancies between the language I'm using and the language that's on the slides with the choices modeling results. So Denver Public Health and Denver Health have a commitment to diversity, equity, and inclusion. And as part of this, we recognize that when we're sharing data, we want to use the right language, and we have guidelines and principles about making sure that as we share data, we recognize that data and numbers do not always tell the whole story. And so to be able to tell the story, we asked our patient population, what is the language that we should be using? And this is what we found, that this is the language that they preferred, particularly in the Latinx populations, that this was very much preferred, least offensive, most motivating. And we recognize that it may be a little bit of a clunky term and it may be long, but it's much shorter than listing all the short and long-term consequences of too much weight for health, like diabetes and asthma. And so we welcome additional feedback in terms of this term and how to use it, and certainly are open to continuing the conversation about how we can destigmatize the use of obesity.
Yeah, it sounds like there's room for testing this in other populations. And Elsie, I know that you're intimately familiar with the use and misuse of BMI as an indicator and a focus on weight as an outcome. How have you addressed this in your work?
Well, I should say, I think the direction that Jennifer, that Denver has taken in emphasizing health and not weight is so critical. We try, and we know that what motivates families to change is not necessarily a number, a metric, and BMI we have traditionally found difficult to use as the motivator, and it puts too much emphasis on weight. And so similarly, I think a lot of what we have tried to do is to emphasize the health aspect of weight management, the behavioral aspects that in behavioral interventions and outcomes that we are hoping to achieve through some of our programs. But I think it's critical for us to start to match our language with the language that will motivate families to change. And I have not seen BMI itself as doing that for some of the patients that we care for. And Jennifer, I think you even have in Denver some qualitative data to support that, particularly I think with your Spanish-speaking population, of just some of the language that resonates and other language that just wasn't felt to be kind of culturally appropriate in the discussion and conversations about weight management.
So Jennifer, you mentioned text messaging as a key element of your program. You also mentioned in passing the collaborations that you've had and with partners, and particularly with Elsie. And I'd like to explore just a little bit, or maybe you could describe how those emerged and how those influenced what you did. And then we'll turn to Elsie for a complimentary comment on that.
Sure. So having completed the modeling of the STAR intervention and establishing this level of support within our health system in terms of this is an intervention that is something that we should consider how we can approach it and how we could implement it. That was something that we shared back with the Choices team who were in touch with Elsie, and the opportunity presented itself where we connected to be able to understand how we might work together and jointly apply for some funding to be able to implement a dissemination and implementation grant.
And so turning to you, Elsie, can you share a bit more about how this evolved with Denver? And I think there are other sites that you're working on with your PCORI grant. And maybe for the purposes of our audience, you could talk a little bit about what PCORI is actually all about.
Sure. So I just read an article from investigators at the National Cancer Institute that have said that the time for implementation scientists has arrived. And I would say we're very excited to see the emphasis on implementation science as it relates to childhood obesity and the funding that made possible the work that we're continuing to do in childhood obesity, and funding through both the Patient-Centered Outcomes Research Institute, but also through the CDC. We were fortunate to be able to apply for funding that PCORI made available for implementation of proven effective interventions. We had already shown that STAR was effective. We had already shown that that Connect for Health with some of those adaptations was effective, and the PCORI funding then allowed us to say, how do we help other health systems adopt proven effective interventions? And I can't stress enough how important it is to be able to not just not just have our interventions end up in a publication, an academic product, and the next grant, but the increase in funding from the CDC, from the NIH, from PCORI, to actually think about how do we take interventions that have already been shown to be proven effective and increase their adoption, particularly among clinical settings that care for disadvantaged children. So I just want to say I'm excited. We're benefiting from the implementation science work, both with the work that we're doing in Denver. We're also working with sites with Prisma Health in Greenville, South Carolina. We're working to further know and study what are the strategies that are going to help clinicians adopt programs like Connect for Health across Massachusetts, and through funding that we have received through the CDC, we're also including some sites in Mississippi. So I think that it's important. I think we still have more research to do to understand other interventions in clinical settings that are, and improve the effectiveness of other interventions, especially as we introduce new technologies in clinical practices. But I am excited to see the emphasis on implementing and disseminating and studying strategies that are going to allow the adoption of things that have already been proven effective. And that implementation science emphasis in the last 10 years in particular has allowed us to continue doing work in Denver and nationally.
So Heidi, I think that Elsie's referring to the funding that your branch provided to her. And I know that this is representative of the kind of work you're doing now at CDC. Can you share some of your other initiatives? And in addition, just to shift the emphasis a little bit, how COVID-19 and the pandemic has affected your work? You're muted, Heidi.
A couple of the initiatives that we have within our population and health and healthcare unit include a project we have called Commit, and that's what we call Childhood Obesity Management with MEND Implementation Team. And similar to the work that Elsie and Jennifer have talked about, this really includes not just the screening component, but really, supporting children from low-income families. And some of that additional work is happening through our CORD projects, which is our childhood obesity research demonstration, where similar to what Elsie talked about, are really what we would call this type 3 or implementation trials, where we take proven effective interventions and really, bring them into venues that are serving low-income families. We want to make sure that, we still are having, support for our families, but we want to make sure that these are acceptable to not just the caregivers, but also to the folks in the office, whether that's behavioral health specialists, primary care, registered dietitians. We have lots of allied health professionals working along with our physicians to really support our families. And so we continue to learn through our Commit and CORD projects. As you said about COVID-19, we've seen a lot of adaptations related to things like telehealth or bundling of services. So if a grandmother or mother is coming in with a child and that person needs their blood pressure or A1C checked, making sure that the family members, at the same time that the child may be getting services related to healthier nutrition offerings, that those things are bundled together. So we're really seeing these kind of great pivots happening because of the pandemic, where we're bringing together more dyadic care. Great.
So Elsie, given the prevalence of obesity, we're not going to be able to treat our way out of this pandemic. What prevention strategies should state or local health agencies be thinking about?
So I have a few, and it specifically, I think, for state and local agencies, but also just in thinking in healthcare organizations, daily have to make decisions about what to implement and the cost of those interventions, and you know, the trade-offs that are being made as budget decisions are being considered. I think that the most important strategy is thinking about various policies, and thinking from a policy perspective, as you said, to what are some policies that could be implemented to facilitate greater access to prevention and treatment services. I think we have to start thinking at a policy level. I think we also have to start thinking of shifting from individual level interventions, or interventions that are strictly focused on changing individual level behaviors, to really thinking about interventions that work across the system. So, or programs, policies that influence a system. So to give you a perfect example, there's terrific data showing that changes to the WIC package, so the package, the supplemental nutrition program for women, infants, and children, that changes to that package of food and services that were made to WIC resulted in some terrific data and evidence from Los Angeles in particular, was found to be effective in preventing the incidence of obesity among low-income children under the age of 5. And I can't stress enough how important it's going to be for us to shift from individual level interventions to really thinking of systems and strategies that can really affect a system. I think some of the other things that we are thinking very carefully about is the funding and reimbursement for not just programs in primary care, but for treatment programs, for healthy weight clinics, for behavioral health services and integration of behavioral health services into weight management programs. And then finally, we're also thinking very carefully about interventions and programs that start as early as you can possibly start, in pregnancy, in infancy, that can interrupt the development of obesogenic risk factors that can be targeted in those first 2 years of life, in particular, when infants and their parents interface the most with their clinicians and clinical settings. So those are just a few examples, but particularly the system-wide aspect of policies and programs that are really targeting system-wide changes to have more effects on prevention.
Heidi, same question.
So I think we've got a number of opportunities, talking about what Elsie talked about systems. In the childcare, early care, and education area, we've seen really great progress on areas like state licensing, which provides a foundation for all the childcares, whether it's homes and centers, quality rating improvement systems, which can allow, for greater reimbursement, say, of fruits and vegetables, along with interventions that have been shown in choices like knapsack, where we have a self-assessment that drives priority action. So we see the policy, the systems, the environment, and the organizations really having interventions at each level. So what we call silver buckshot instead of a silver bullet. And I think in clinical care, we're starting to see that. So for example, in the state of Missouri, they have a state plan amendment that now allows reimbursement of not only the diabetes prevention program for adults, but their family-based therapy treatments for children. And so if we think about what layers are occurring in Missouri, we can think about what are all those levels of exposure that can benefit a child. So thinking about the clinical system, so the reimbursement, the screening, and where STAR can fit into that as an example.
Mm-hmm. And Jennifer, you're really on the front lines of this and have been invested in the treatment side. Are there policies underway or things that you think are more readily applicable in Denver as a municipality than perhaps elsewhere?
I think there's many policy options that can be explored in terms of being able to impact too much weight for health. And so one of the other strategies that we did model with the Choices team was looking at a sugary beverage excise tax. And so that was certainly something that showed very promising results, was cost savings in terms of the results, and certainly had an even larger population impact in terms of preventing and reducing too much weight for health, as well as really being able to show some impacts on preventing oral tooth decay and the prevalence of diabetes.
Great. So one last question for you, Elsie. The Denver modeling suggests that this is a cost-effective strategy that's than other clinical strategies. Are there other new or emergent technologies or strategies that could contribute to lowering the cost? And what is the potential role? You mentioned electronic health records as one of the adjunct tools. Could you expand a little bit on what you think the emergent technologies will bring to this?
Sure. So for better or for worse, what COVID has introduced is how much we can do virtually, and in some cases how similarly effectively we can provide counseling through virtual visits, through telehealth. Reimbursement for that is, as you heard Heidi mention, is going to be a challenge. But I think one of the most important technologies that I'm seeing as we start to think about adaptations, and actually we're forced to think about during the pandemic and the first surge, was to think about how do we deliver weight management when we can't see children in the office, when we close down our clinics and have to communicate via telehealth. It introduced a whole host of other challenges that we've worked and we have gotten help nationally, learning from others of how they tackled the move towards telehealth weight management. But I would say there's quite a bit of learning to do once we shift to kind of COVID recovery, in thinking of what are some of the things that should be sustained from from the technology, the telehealth technology. I think so that's a very specific technology that we should think of keeping and thinking of how to maximize the experience for delivering weight management through telehealth and virtual care. I think very specifically with electronic health records, when we tested STAR back in 2010, in pediatrics, for example, ours was the only best practice alert. We didn't have a lot of competition, and I can bet that is no longer the case. We are competing with, people have caught on, and the use of best practice alerts is competing. We're competing with other best practice alerts. And I think we have to start to think of what are the other ways to really deliver at the point of care for clinicians the information that they need to be able to deliver high quality care. For us in 2010, the answer was a best practice alert, a smart set. And we've been thinking really carefully about what are some of the other ways that we can deliver point of care guidance and assistance to clinicians as the landscape changes, and best practice alerts are now incredibly common and contributing to some kind of alert fatigue. So as with any intervention, there's always room to use and adapt to new technology. There's room to think about how emerging technologies can make our adoption of STAR, of Connect for Health, even easier and better, and improve the experience, not just for patients, but for the clinicians that are interfacing with it. So we continue to look for ways to adapt it. So it's just some ideas there of, there's still work to do to think of emerging technologies and how we continue to use the electronic health record as a way to introduce content to clinicians at the point of care.
Right. Thank you. So I think we're beginning to see, and there was a study in Philadelphia that showed that the prevalence of obesity was increasing in kids as a result of the COVID-19 pandemic, and the lockdown, which restricted physical activity, probably the increased reliance on ultra-processed foods, and the amount of screen time. So what do you know about the impact of COVID-19, and how would you begin to think of strategies that we need to address it both now and in the future? And let's start with the local perspective in Denver, and then move to the clinical perspective with Elsie, and then to you, Heidi, for a more federal perspective.
In Denver, we certainly heard from our providers that during COVID, at the time that we were implementing this clinical pediatric weight intervention, that our providers were seeing a dynamic and universal increase in too much weight. And so we were glad that we did have something to offer them in terms of having the STAR Connect for Health intervention that we used with the text messaging. And with that, we really were working to lead with resources as part of this, in terms of this approach and what we were offering in terms of trying to support routines and routines with sleep, and making sure that we're supporting with the right resources and connecting as far as social and emotional health. These are all the same things that kids really need and families need during an intense and stressful time, such as a pandemic. And so at the time we were implementing this, we really worked to be responsive and add additional education, leading with these resources that really address some of these issues in terms of how to be able to find food, making sure that we could lead with resources around housing and rental assistance, and being able to support connections to unemployment benefits, and also really adding additional text messages to, again, link them. All of this was included previously in terms of leading with these resources, but we also made sure we added additional text messages to be responsive. And so as a result, we're even considering and exploring, is this a strategy that really could be something that we look at that is beneficial for all children, regardless of weight status.
Great. Elsie, from the clinical side.
I think I talked a little bit about the most profound impact that COVID had on obesity management was the need to shift our thinking of how to deliver weight management to a virtual setting. That has, we still continue to learn about how you provide weight management through Zoom. How do you provide it through phone, if that's what people have available or families have available. So that was probably the most critical and quick adaptation that we needed to make. I think now that we are emerging from the surge in particular and thinking of recovery, there are two things that we are kind of keenly thinking about. Jennifer mentioned one of them, which is how do we prepare our clinicians to be able to be ready for what's going to be a kind of comorbidity of obesity with social risk factors, and how do we move from screening and move from screen and refer to actually screen and tailor and customize your treatment plan based on that social risk factor. So there's a lot of work happening nationally on the use of screening for social determinants to develop social risk informed treatment plans. And it's one thing that I feel very strongly about, maybe because I'm a pediatrician, that for so many years, those of us who are pediatricians have just, the screen and refer we have to do, but it's so much more satisfying if we screen, refer, but customize our treatment plans based on the social risks that are being endorsed at that day's visit. I can do so much of a better job if I customize my treatment plan for a child or a family with obesity who also endorse food insecurity by really, engaging with the family about how to follow through on some of our recommendations if they're food insecure, or if they're housing insecure, if they don't have transportation. And I don't think we've done that yet. And I think it's time that we think about doing that, not just for obesity, but for chronic disease management, is this idea of social risk informed care. I think the other thing that we are seeing and thinking very carefully about is how to bring in more behavioral health support into the weight management programs that STAR, Connect for Health, and similar treatment programs across our organization. Behavioral health is going to be critical as we think about the recovery phase post-COVID, and how do we rethink the integration of behavioral health in weight management and chronic disease management. So those are I think were during the surge, it was really a race to think of how do we deliver good quality weight management through virtual visits, through linkages to resources. But now during the recovery, it's all about getting much better at social risk informed or social risk customized plans and the integration of behavioral health into our programs.
Heidi?
Thanks. And just to add to what Elsie and Jennifer talked about, we've really seen an influx of funds and support programs, especially to address food and nutrition security in the last number of months here, just because we continue to see the spikes in hunger and food insufficiency at the beginning of the pandemic. But that unstructured time, like you talked about, Bill, it's like kind of like having school closure. It's like summer continues. So we really do need this transformative change, and really, really considering, aspects related to culturally acceptable foods. We're working on that with nutrition standards in food banks and food pantries. Feeding America and other partners have really, gone to the communities for that last mile. And that's when, when we're talking about screening for social determinants of health, like food insecurity, it is that next step. And so, there's a lot going on in the U.S. government as it relates to more online certification of programs like SNAP and WIC. There's a lot of engagement that USDA has with a lot of clients and other partners to get input into what worked during the pandemic related to some of the waivers and some of these online approaches that make it easier for families to get to nutrition assistance programs and to stay on those programs. So I think there's a lot that's happening in the nutrition space. With physical activity, we really need to spring back, from where we've been. And I think as we learned during the pandemic, this reduced risk of fomites, a lot of the safer at home and park and recs were unfortunately closed down. And so we really need to support our youth through green spaces and park and rec, and really get families, out there moving together, supporting them through safe environments. Thank you.
Great. Yeah, thanks. So just one final closing comment from me before we go on to closing comments from the panel. And Elsie, thank you for talking about the social risk informed care. But in some respects, it's like closing the barn door after the horse is gone, because it doesn't really get at the deeper drivers that foster those inequities. And I think that brings us front and center to structural racism and the kind of compartmentalization of housing and other elements. So, for example, I was in a conversation yesterday when I realized that we didn't know the extent to which the eviction rates fostered food insecurity. It may be, it's likely because such a big chunk of a family's budget goes to housing, but the compartmentalization of these benefits has really stood in the way of kind of thinking of strategies that would really begin to address these underlying drivers for obesity and for inactivity. Before we close, and we're at that point, I'd like to let you, all three of you, make whatever point you choose about how you see opportunities that will promote healthy weight and address health equity in the healthcare setting. So Jennifer, let's start with you. I think you're still on mute.
With the opportunity right now, with the demand for primary care, I think this is the time to really make sure that we are selecting interventions that show promise to addressing health inequities. And I think having interventions available as people are returning to the health system, and there's such a high demand like STAR and like Connect for Health that have shown that they're a great value for the money, can reach a large population, impact health, and certainly show promise for addressing health inequities, are strategies that should become more broadly available for our health systems to play a role. We know that they are not the only ones that we're going to need interventions in all settings, and we really know that this is the time and our kids are worth it.
Elsie?
So I just want to echo that. As you can imagine, I completely agree. I think we are, to your point, Bill, there has been a historic underinvestment in low-income communities to really, that is frank structural racism, and that have led to more Black and Hispanic children disproportionately affected by obesity. I think it's time for us to really think about those investments in community health and how we put health back into health care. Others have said it. I think there are opportunities right in front of us. I think there are opportunities in President Biden's American Rescue Plan. I'm hoping to see quite a bit of opportunities through some funding in the plan that can really think about those investments and how they could be put towards prevention and adding more health into healthcare.
Great. And Heidi?
Thanks. There's just so much work to be done, but I think, keeping hope alive is really important. I think the work that we're doing in federally qualified health centers, like work like STAR and Commit, are so important because they're bringing those important interventions to the communities in need. And I think, we really need to think about the pipeline of professionals and community health workers. How are we supporting not just, token representation, but real inclusivity of our allied health professionals? How are we really ensuring, that the professionals who are going to be able to support our families in the next decades really come from the community? So I think thinking about how our education systems, from early care and education, schools, minority serving institutions, because those are the future clinicians and health professionals. So I think we all can also think about that pipeline.
Great. Well, thank you all, Jennifer, Heidi, and Elsie, for your participation today. This was a great panel, and I think we achieved the objectives that we sent out at the beginning in terms of understanding the cost effectiveness and its application in clinical settings. In the chat and on this slide are ways of learning more about the Choices Project and joining the Choices community of practice. And please let us know what you think of and thought of today's presentation. There's a link to the survey in the chat. And this webinar will be followed immediately right now by a discussion hosted by the Choices Community of Practice. So great. Thank you all. And we'll see you on the next Zoom. Bye-bye.
Bye, everyone.